Good morning. My name is Mary Claire Beadala, and I will be your moderator. Welcome to the workshop, Late Effects of Pediatric Transplant, Transitioning to Adult Care. I'd now like to introduce Dr. Robert Krance. Dr. Robert Krance is a professor of medicine at Baylor College of Medicine and the director of the Pediatric Bone Marrow Transplant Stem Cell Transplant Program at Texas Children's Hospital in Houston, Texas. Dr. Krance has been involved in bone marrow transplantation for more than 30 years. His research interests include the use of alternative donors and less than fully HLA-matched related donors for transplant, and the impact of viral infection post-transplant. Please join me in welcoming Dr. Krance.
Good morning, everyone. I want to thank, first of all, Ms. Stewart and the staff of BMT InfoNet for inviting me to speak today. I am going to be talking, as was introduced, on the long-term healthcare issues of pediatric patients who have been transplanted. I want to say from the start that I use the word patients or survivors because there's no better or easier word that would make sense, but I know some people may not want to necessarily be labeled or considered as that, but it's, as I say, there's no better term than I have. I think this is a very important topic because long-term healthcare management is so essential to quality of life. And as clinicians, we have two goals. We want everybody who has to have a transplant to basically successfully get through the transplant. And we also want to accomplish that without causing undue harm or delayed complications. And so for patients who've been transplanted, I think it's important to recognize these elements so that, well, if they can prevent complications, they're aware of them and they can deal with them. Or if they do develop complications, that they do have effective treatment that's available to them, and they receive that as soon as possible, so that the benefits of the treatment can be before there's lasting injury. The other element of this talk is that we're encouraging people to develop lifelong healthy habits, because that is a big part of long-term healthcare management. And then take advantage of all the measures that you can use to improve quality of life. For instance, BMT InfoNet has a number of opportunities for patients who've been transplanted in the later years. So let me start off by saying it's important that each person recognize the specific circumstances of their treatment and their course. The illness for which transplant was recommended is one. If there was treatment pre-transplant, that you should be aware of that. You should also be aware of the treatment that was used to perform the transplant. For instance, now not all patients get ablative therapy, which was the standard a decade or more ago. Some patients receive non-myeloablative or reduced intensity, and that can make a difference in terms of the transplant-related complications, post-transplant care. And also the graft-versus-host disease preventive therapy and complications that may have arisen during the transplant course. Unfortunately, although transplant has been available for over 50 years now, much of what we know about post-transplant care still remains unclear or uncertain. In many cases, there are data to use to develop a care plan, but in other cases, treatment is based upon what groups of physicians think might be the best. And in some cases, your individual center may have their own particular protocol. Listed here are 3 organizations that do have guidelines, and people may be interested in looking at these to see if there's something that they find useful. Something that's extremely important and often not addressed or not fully managed is that of re-immunization. It's one of those things which is sort of a non-brainer, but unfortunately when patients, if they're not being cared for, say at their transplant center, and are being cared for by a private physician, the private physician may not be aware of the need for a re-immunization schedule, or may not have that, or may be skeptical of the need for it. So I encourage every person to obtain a schedule of re-immunization, and they make that available to their physician so that that can be carried out. When should immunizations begin? There's no set time. Some centers look for immune recovery by looking at particular populations of immune cells. Other centers don't do that. They wait for a year. Our own center looks to immune recovery, but also we will provide patients with a vaccination against pneumococcus, the Prevnar vaccine, and against the DTaP vaccine for diphtheria, tetanus, and pertussis. And we look at the pre and the post response to the vaccination. And if the response looks good, then we will proceed with the full schedule. In the first year, and usually it's a year or more after transplant before starting the vaccinations, the vaccination should only be for bacterial infections and for using non-live viral vaccines. After the second year of transplant, it's possible to get live virus vaccines. Those include the measles, mumps, rubella, varicella, and the human papillomavirus, HPV. The reason for that is the longer time to immune recovery, we think it becomes safer for the use of live viral vaccines. Additionally, every patient post-transplant should get an annual flu vaccine, and I think you can probably look forward to getting vaccine against COVID on some regular basis in the future. Most patients who undergo stem cell transplantation do so for malignancy like leukemia or for bone marrow failure, aplastic anemia. But there are patients who undergo transplantation for certain genetic disorders. It's important that they keep this in mind because while transplantation may improve some of the elements of their illness, it does not improve all of the elements because the underlying disease is not totally cured by the transplant. So what's an example of that? Patients who have Fanconi aplastic anemia. That's a bone marrow failure disorder, but it also has a predisposition to get cancers of the gastrointestinal tract, which are unrelated to the transplant or its therapy. Or patients who have another condition called dyskeratosis congenita, which is another marrow failure disorder, but it also can cause liver and lung disease, and that's independent again of the transplant. So for certain illnesses, transplant does not address the underlying genetic problems completely, and it's important to remain knowledgeable about that because that will make a difference in your long-term care. So taking this sort of by system, starting out with oral care, pediatric patients are often transplanted early in life, and it's in the early years that organ systems are developing. One system are the teeth, the oral cavity. Treatments like radiotherapy delivered during this young years can cause interruption of tooth formation. Teeth can fail to erupt. They may have poor enamel formation or poor root formation leading to tooth loss. We think it's very critical that patients have annual oral care at least. Of course, most people do see the dentist annually, but in this particular case, it's very important so that patients have the best possible outcome related to their teeth. Orthodontia may require specialists if there is a problem with teeth formation or teeth development, so be aware of this. Getting to the heart of the problem, talking about heart health. Heart health is something that's going to be a lifelong endeavor for patients who have undergone transplant, especially if they receive certain chemotherapy or radiotherapy. The incidence of heart disease in transplant patients is approximately 10 times that of the regular population. It can lead to heart failure, like a cardiomyopathy, but really any element of the cardiovascular system can be affected, including blood vessels. So maintaining a healthy heart style is currently very important. What are some of the risks for patients? Not every patient is at risk, but patients who have received anthracyclines, such as doxorubicin, patients who have received total body irradiation, or patients who have received chest irradiation, say mantle irradiation to treat lymphoma, or the combination of those, are more at risk than any other group. But again, you can contribute to your own heart health by avoiding unhealthy habits such as smoking, diabetes, high levels of cholesterol, and so forth. So this is a total health picture, not just related to your treatment. The current recommendations try to stratify patients based upon the amount of therapy they've received. Patients can be labeled as high risk for heart disease, intermediate risk, and low risk. You can see the reference below that you can look that into further details. The patients who are considered high risk probably should undergo an echocardiogram every 2 years, whereas those that are considered intermediate would be considered echocardiogram every 5 years. And those that are considered low risk, it's probably not necessary that they have a regular echocardiogram performed. But being aware of heart health, I think, again, is very important. The bone, the skeletal system, we typically don't pay much attention to that, but bone health is an issue for patients who have been transplanted. Patients who've received total body irradiation may develop bony tumors called osteochondromas. These are bony outgrowths that occur at the metaphysis, or the growth plate of bones close to the end of the bone. These are almost always benign. A simple X-ray can often be diagnostic. It doesn't require further evaluation. Typically, they don't need any therapy unless there's some cosmetic issue, or if they cause some functional pain, say, in movement of a joint. If so, they can be removed. Another condition that can occur is avascular necrosis. This is an unusual condition. It typically presents in the hip, and patients have pain with walking or running. It's not clear to the etiology, but use of steroids for prolonged periods of time and sometimes radiotherapy are implicated at this. What happens is that the head of the femur basically undergoes necrosis. It's thought to be due to a vascular injury, and as I say, it's not clear why this happens. An MRI is diagnostic, and treatment can include symptomatic care, in some cases surgery, and rarely it can require hip replacement. Osteoporosis or osteopenia is another complication, and it's present in at least a quarter of patients post-transplant. The way the diagnosis is made is by a study called the DEXA scan, which is a nuclear medicine study. But because it's so common, most centers just recommend that patients be taking calcium and vitamin D to promote bone mineralization. Osteoporosis is more common among patients who've received total body radiation and prolonged therapy with steroid, and other hormone deficiencies can contribute to that. Smoking and excessive alcohol intake can aggravate this condition, and physical activity can help deal with it. So being active helps bone mineralization. The kidney. The kidney typical tests are BUN and creatinine, and these are often normal, despite the fact that transplant patients can have endured injury to the kidney, and this kidney injury is quite frequent. Kidney, like many of the other organs in the body, has a certain redundancy of function, so that there has to be a great deal of injury before a blood test like the BUN or creatinine might show up. But patients who receive radiotherapy, or patients who receive certain chemotherapy drugs like ifosfamide and cisplatin, obviously patients who receive tacrolimus and cyclosporin, these are all agents which can contribute to kidney injury. And also patients who've had complications during the transplant phase, like transplant-associated microangiopathy, or a patient who's been required dialysis at some point during the transplant course, all have sustained kidney injury. The best way to evaluate kidney function is by a functional test, creatinine clearance or glomerular filtration rate. So we usually will require one of these tests a year after transplant to determine what the ongoing baseline function is. Typically, kidney function doesn't decline after sort of reaching a plateau, so that's a good sign. But conditions like hypertension must be managed aggressively and may require intervention by a nephrologist. One important thing is to avoid further injury to the kidneys, so we are very adamant that patients should not receive chronic treatment with ibuprofen or naproxen. These are called non-steroidal anti-inflammatories. You know, a single dose here and again, not significant, but chronic use of these medications is discouraged. Likewise, when you see a physician for some condition and you're given a prescription, I think it's always important to tell the physician that you do have concern regarding kidney function, and is this particular medicine a problem for you? And as stated above, we would recommend anybody who has proteinuria or hypertension to be seen by a nephrologist. Lung injury. Nothing frightens transplant physicians more than lung injury because there's so little you can do when lung injury becomes severe. In the immediate aftermath of transplant, the one condition is bronchiolitis obliterans, which is thought to be a complication related to graft-versus-host disease. It has many of the symptoms to suggest asthma, such as wheezing and puffy chest and prolonged expiration. But it is different, and the therapy is not good and requires ongoing care. Later on, lung injury can be related to the effects of prior treatment, like drugs from busulfan or bleomycin, patients who received irradiation to the chest or TBI. They can develop basically scarring or fibrosis of the lung, which can lead to restrictive lung disease. The symptoms of that would be, becoming short of breath with really minimal activity. The best way to monitor the lung is with pulmonary function tests. Usually children older than 6 years of age can perform these tests. We typically obtain pulmonary function prior to transplant, and then during the first year after transplant. If the tests are stable, it may not be necessary to repeat these in the future, but if there's a decline, certainly we would repeat them and follow them as long as there's ongoing decline in pulmonary function. No smoking, obviously, no smoking, and you all know about secondhand smoke. Again, we recommend flu vaccine and Prevnar vaccines to avoid the possibility of developing infections that you could avoid. Skin health. Chronic graft-versus-host disease can cause major changes to the skin, particularly scarring and thinning or atrophy of the skin. And these can be nitises, beginning sites for development of squamous cell cancer. But skin cancer like melanoma or basal cell carcinoma can also occur. We think that annual skin exam by your physician or by a dermatologist is important. Certainly if you have pigmented moles, they should be followed by a dermatologist because they have the potential for developing a melanoma. So following these on a regular basis is very important. No tanning booths. Now, some of the things we just talked about, they develop over time. But changes to the glandular system, the endocrine system, are often present in the first years after transplantation. And particularly for children where growth and development is so important, endocrine function is really critical. So the pituitary gland, the major gland for the endocrine system in the brain, which controls the thyroid and the adrenal gland and the ovary and testes, also secretes growth hormone. It is very important that this gland have adequate function. So measuring linear growth and following that is quite important. The pituitary can be affected by irradiation to the brain, obviously, or patients who've had disease involving the brain like CNS leukemia or brain tumor. If a patient has growth hormone deficiency, this can be determined by looking at a number of things. There are blood tests like the insulin growth factor, obviously following height over time, obtaining a bone age, to compare that with height to be certain that things are proceeding according to the norm are measures of that. You can perform a growth hormone test that's a little bit more involved and usually is done by endocrinologists. Patients who have other hormone failure can also have delayed or inhibited growth, so the thyroid and gonadal function can be quite important. For patients who have growth hormone deficiency, it's possible to treat them with growth hormone. It must be started before puberty to have any benefit, because once puberty occurs, bone growth is going to be stopped. And so starting before puberty is critical. There were concerns in the past about growth hormone causing the recurrence of the primary disease, so it was a cancer, but I think that's been pretty much excluded. And whether or not it could stimulate some other tumor, I think most endocrinologists and bone marrow transplant physicians don't believe that's an issue. Height is so important in today's society, and so I think this needs to be addressed, and you should discuss that with your care team. The thyroid gland, especially for patients who are receiving irradiation to the chest or total body irradiation, may lose function. It could be related to pituitary injury, but more typically it's due to thyroid, decreased thyroid function in response to thyroid stimulating hormone. It's easy to treat with thyroid hormone extract. The only point I would make here is that also other kinds of thyroid issues, including hyperthyroidism, where the thyroid is overactive, can occur rarely. And thyroid cancer is something that needs to be considered. On an annual exam, patients should have palpation of the neck looking for thyroid nodules. Some centers recommend ultrasound examination. Sexual development, a very critical element, as everyone knows. And for males, the testes control development of masculinity and pubertal growth. We'll talk a little bit about the difference between testosterone secretion and germ cell function, but total body irradiation and certain agents like cyclophosphamide or platinum agent drugs can affect the testes. It's important to recognize that for boys who are treated before puberty and receive total body irradiation, it's very likely that they will be sterile because the effect of these agents on the testes are such that the sperm cells, germ cells, are lost. They may continue to go through puberty, or they may have delayed puberty. And it's important to test boys early, 10 or 11 at the latest, looking for evidence of testicular failure. We'll discuss those tests on the next slide. And for pubertal males, there is the potential for attaining fertility, especially given if after several years post-transplant, it may be that the fertility will recover as sperm's production returns. The only way to be certain about fertility, though, is to do a semen analysis. As I mentioned, there are the germ cells, the sperm cells, and there are the Leydig cells, which secrete testosterone. The germ cells are very sensitive to therapy, and that's why for young boys they often are eradicated. Whereas the Leydig cells are more resistant to therapy, and so they will secrete testosterone. So typically, patients may masculinize, but they will be infertile. For females, the story is somewhat different. A female at birth is born with all of the follicles or ova that are going to be there for life, and they will decline over life as a woman goes through puberty and menstrual periods. Each of those times, follicles are lost. When the number of follicles decline to a certain level, a woman goes through menopause. And the effect of radiotherapy and certain chemotherapy agents is actually to reduce the number of follicles. Young girls, because they have more follicles than females at puberty or post-puberty, who've already lost the number of those follicles through development, are more likely to retain the ability to go through puberty and may retain fertility, whereas fertility is almost always lost for pubertal or post-pubertal women. The only point I want to make here is that if a woman pertains evidence that they may be fertile, it's important to for family planning to consider that earlier rather than later, because over time fertility may be lost and menopause may occur. For those patients who are fertile and do have offspring, or who are able to become pregnant, there is no evidence that there is an increased risk for congenital anomalies or genetic disease in offspring. So that's, I think, a comforting thing. I mean, the risk for infertility is high, but for those that are fertile, they can be comforted the fact that there's no evidence that there's increased risk. There are risks for transplant survivors who are female going through the pregnancy. They may have miscarriage, or they may have some difficulty with delivery due to the changes to the uterus, but infants have always been healthy. Eye and ear health. I mean, obviously, seeing and hearing is without doubt very important, but it's important beyond just the senses themselves. I mean, it's important in terms of schooling and occupation and so many things. Hearing is usually not affected, except for patients who have had higher doses of a cranial irradiation, over 3,000 gray. It's also certain drugs can contribute to hearing loss, like cisplatin. We do an audiogram in the first year post-transplant to have a baseline, but in general, hearing is preserved. Eye exam is necessary at least on an annual basis because of the risk for cataract development among patients who've had total body radiation, and in some cases for patients who've only had chemotherapy. Cataracts can develop. They don't always necessarily need surgical removal, but if there is, for instance, cataract formation in one eye that leads to a greater loss of vision, it is important to correct that. The liver, like many of the organs in the we've already discussed, is sensitive to drugs and irradiation. Complications during the transplant phase, like veno-occlusive disease, may cause permanent changes in the liver. The liver also is more susceptible to iron overload. So with transfusions of red cells, iron accumulates and it's stored in the liver. And if the accumulation of iron is significant, it can lead to liver injury, even to liver cirrhosis. We use the protein ferritin as a way of assessing the storage iron, and if it exceeds a certain amount, we recommend that patients get a MRI of the liver, which lets you quantify the amount of iron in the liver. If it's high, then it should be removed, and the current favored way of removing it is by phlebotomy, just withdrawing blood. That allows the iron in the liver to be withdrawn and used to make new red cells. You can also use certain drugs to chelate iron. Besides the liver, the heart and the pancreas can also be sites of accumulation, but usually they are less susceptible to iron accumulation than the liver. Patients who have abnormal liver function tests unrelated to iron can have a condition called non-alcoholic fatty liver disease. These patients usually suffer from obesity, and in this condition, fat gets deposited and stored in the liver. As it gets worse, it can cause steatohepatitis, fat hepatitis, which also can cause cirrhosis, and actually it's one of the leading causes for liver transplantation. It can be dealt with by controlling diet, and so that's another of those areas where lifelong habits can be very important in preventing certain complications. Metabolic syndrome, often associated with non-alcoholic fatty liver disease. It's a compendium of symptoms and signs. It usually includes hypertension, abdominal obesity, waist circumference is large, abnormal cholesterol and triglycerides, and usually abnormal glucose metabolism, which can ultimately lead to diabetes, which is a complication that is all too frequent among patients who have this syndrome. Apart from leading to diabetes, it can cause cardiac disease, and stroke and infarction are also part of the side effects of the results of this syndrome. The cause is not clear. It seems to be more common for patients who've received steroids and perhaps radiation therapy and certain drugs. Patients who are growth hormone insufficient may also be susceptible to the development of this metabolic syndrome. But by and large, it's not clear how it happens. Obesity can lead to inflammation. We know that, and so there may be some element of inflammation. But the way to manage this, and it's shown to be effective, is by controlling diet, maintaining weight, and maintaining your physical activity. So these are, they seem to be sort of obvious, but they do lead to improved quality of life. And so we're very it's a very important step in terms of post-transplant care. Malignancy. It seems unfair that after somebody's treated for leukemia or lymphoma that they need to worry about malignancy. The exact incidence of cancer in post-transplant patients is unclear. I mean, there are many elements to be involved in that. Exactly what populations are you comparing, things like that. Some of the best reports say that it may be about twice as common in the population as non-transplant patients. It's also true that for many of these, the risk increases over time, meaning that, for instance, you see below that MDS, which is myelodysplastic syndrome, and AML, those are usually seen, fairly early in the post-transplant period, and they're really limited to patients who have undergone autologous transplant using their own bone marrow. And so it's assumed that there's some injury in the treatment that leads to the development of AML. And lymphoproliferative disease is a viral disease that can occur in the post-transplant setting, which is fairly easily managed. But other cancers are more common and do not usually begin to appear until 10 or more years after transplant. So this is the argument for ongoing care in one term, because an annual exam and an annual history can be very important in discovering these cancers and getting the appropriate testing. As I said, it's not clear why it happens in transplant patients. There are a number of variables. It may be related to the patient's own genetics, or it may relate to the treatment that they receive, like radiotherapy or certain agents. The diagnosis may be one that sort of, like lymphoma, is associated with a higher occurrence of cancer in the post-transplant period. And the younger patients seem to be more likely to develop, younger at the time of transplant, are more likely to have a transplant later in life. The annual exam, as we talked about, is important for discovery, but there are particular studies right now that should be done. So breast cancer for women who receive chest irradiation or receive total body radiation with anthracyclines seem to be at more risk for breast cancer. And currently now it's recommended that certain patients, and you can discuss this with your physician, should begin with a mammogram and a breast MRI at 25 years of age annually, or 8 years after the completion of therapy, whichever is longer. Some centers are not familiar with this, so your team is going to have to reach out and explain why this is being done, but this is recommended. We've already talked about squamous cell carcinoma related to chronic GVHD, and then patients who've had CNS leukemia or cranial radiotherapy may also be more likely to develop a CNS tumor. In my own experience, probably the one item that the parents are most anxious about is, will radiation affect my child's ability to learn? Will this somehow make them uneducable or make them in some way delayed? And there's a lot of data out there, both for or both saying yes and no. But the largest compendium of data says that the patients who've had these treatments maintain IQ and performance within the average population range. However, we do think it's very important that patients have neurocognitive abilities examined, especially patients who've had TBI and cranial irradiation beyond the usual amount, or patients who've been transplanted at a very young age. And so neurocognitive testing can be quite informative in that respect. It's ideal that neurocognitive testing should take place before the patient starts transplant, but that's not always possible. But certainly in the first year after transplant, if they've had some of these treatments like irradiation, they should undergo neurocognitive testing. And it's probably important that this testing be repeated at various time points along the child's life. Here I recommend doing it if they move from preschool or into first grade, or when they go to junior high or middle school, and maybe again when they go to high school, because the neurocognitive testing may show that there are problems in certain areas like memory or concentration or organizational skills, but these can be dealt with if they're recognized. And there are many ways to deal with this so that the child does not suffer because of not having the opportunity to have the appropriate education. So timely and appropriate intervention is important. Fatigue is very common among transplant recipients. Usually it begins to improve after several years, but not for all patients. And fatigue, manifested by daytime sleepiness, has been documented in almost 25% of post-transplant patients. And unfortunately, fatigue can lead to many things. It can lead to withdrawal from being active in life. It can be associated with changes such as it can be associated with depression or anxiety. And there are things that can be done to help people who have fatigue, and if recognized, it should be dealt with. So we do want people to be aware of fatigue as being a prevalent complication in the post-transplant setting and reach out for help. Next slide. Finally, I made the point throughout this presentation about maintaining an exercise program. Being active is so very important. The only point I want to make here is that because of the issue of cardiac and pulmonary complications, that prior to embarking on an exercise program, that you have a clearance based upon your cardiac and pulmonary function, and that's easy to obtain from your transplant physician or from your caregiver. And I think as long as the function of the heart and lungs are sufficient, you should be able to have an exercise program. I would recommend that you not begin training for a marathon, but work into it gradually, but have an organized program, perhaps with a buddy, so that you use that as a way of sustaining your exercise program. Last slide, please. So the final thoughts I have are it's very important that pediatric patients, as they age, and their parents, as they help them age, create a mindset of establishing a long-term, lifelong health plan. As part of that, you should have contact with your transplant center, if that's available to you, or if not, you should find a knowledgeable provider in your locale. And I think in most cases, your transplant center can help you with that. And they certainly can now provide the right information to your caregiver so that there's some coordination. And the second part of this is that having healthy habits, diet, exercise, two of the most important ones, and avoid unhealthy behavior habits like obesity, smoking, drugs, and treat symptoms such as anxiety or depression, especially if it inhibits or restricts your life. I think healthy habits are essential to promote healthy adults. And with that, I conclude my presentation.
Thank you so much. Dr. Krance, that was an excellent presentation, and I'm sorry you had a little technical difficulties there, but you recovered wonderfully. We're now going to take questions. As a reminder, if you have a question, please type it into the chat box on the lower left-hand corner of your screen. All right, our first question is, what diet, exercise, or even hormones do you specifically recommend for pediatric patients after a BMT?
So, obviously that's the critical question. So exercise we recommend is basically whatever the patient feels like they can maintain. And I think it should be a combination of cardio as well as muscle development. But whether you choose, say, a treadmill or bicycle or even running as your cardio, and whether you decide to lift weights or do resistance type training, I don't think that matters. It could be swimming. I just think the important thing is that you have something that you do on a regular basis. Doesn't need to be every day, but it should be, on a regular basis. You say, I can do this 3 or 4 days a week. The diet should be, the diet that most people hear is the Mediterranean diet. So it should be a diet that's low in processed foods, obviously low in fats that are not considered healthy fats, and it should be caloric appropriate, not caloric dense. So I think if the caloric need, the caloric content meets your physical activity and your weight needs, and you're doing physical activity on a regular basis, that's what we expect. I take care of primarily children and adolescents, and eating fast food and processed food is sort of a way of life, especially when patients go away to school and are not under parental supervision. But I think if that starts at an early age, that I think children, as they grow older, are likely to pick that up and understand it as being important. So that's my recommendation. If you need more formal instruction, I think consulting with a nutritionist at your transplant center can be very helpful in that respect. Now, for patients who have diabetes or have cholesterol or triglyceride issues, that's a more specific thing, and I do think they should discuss that with a nutritionist.
Okay. And they also asked about hormones. Are there specifically hormones that you prescribe to patients? And what can you say a little bit more about that?
Generally, we find that if patients are hypothyroid and need thyroid replacement, we will do that in conjunction with the endocrinologist. But the common drug is levothyroxine or Synthroid, and it's based upon weight and then response. So that's fairly simple, and there's no brand name that stands out there. For hormone replacement therapy, the options are much broader. Let me talk a little bit about female. Hormone replacement therapy, we favor the use of patch over oral estrogens because that seems to be, safer for the liver in terms of the estrogen dosing than does oral estrogens, but sometimes that's not sufficient. The one caution there is that, generally speaking, patch hormone replacement therapy is not sufficient for contraception. So if fertility is present, or at least it's being considered, that may not be enough to prevent pregnancy. We work again with endocrinology, or in some cases with gynecology, and gynecologists and endocrinologists don't always agree on the best way to do this. Some advocate not using a combination with estrogen and progesterone so that patients don't have menses. Others feel like the menses are important as part of a protocol. So I would not want to make a categorical claim here, but would want you to discuss that with your care providers. For males, the treatment is testosterone. One of the slides there talked about cryopreservation of sperm. So if fertility is a consideration, but hypogonadism is still a concern as well, and testosterone replacement is considered, patients should probably cryopreserve sperm, because if you do receive testosterone therapy, you will lose spermatogenesis, at least for a time, and it may not recover.
All right, that's really helpful. Our next question is from a parent whose child received a cord blood transplant for ALL at around 10 months old. They are curious, what are the significant things they should be on the lookout for as far as late effects? And how can they help their child thrive?
It's a very good question, and my advice is going to be a little bit generic because without knowing specifics, for instance, I would suspect that at a 10-month of age, perhaps the center eschewed using radiation and used a chemotherapy-only regimen, trying to avoid the effects of cranial irradiation on pituitary and growth. But if not, and they did receive irradiation, then growth is going to be one of the major concerns. And I think that following, they should see an endocrinologist relatively early in the post-transplant course, even before necessarily any symptoms or signs of growth failure have developed. If it was a chemotherapy-based regimen, it depends a little bit, again, then on the drugs used. As we said, a drug like cyclophosphamide is very likely to lead to a loss of sperm production. So, and it also may delay puberty. So, I don't know what the age of the child is now, but as the child approaches a pubertal age, they should be studied for whether they're going to actually begin puberty. If not, treatment should be started right away. It should not be delayed. You don't want to add delayed sexual development on top of all the other issues a patient who's been transplanted can face. The annual exam should also look at, adrenal gland function and thyroid function. Those are pretty straightforward and generally can be, quite easily dealt with. Beyond that, depending again on what the pre-therapy was before transplant and what drugs were administered, whether anthracyclines, derdomycin would be a common one used for patients with acute leukemia. It may be necessary that they have an annual echocardiogram, or at least a biannual echocardiogram performed. The child is probably too young for pulmonary function, but as the child comes closer to 6, we would recommend pulmonary function studies, and they should have a sense of what the renal function is so that they're aware of anything that might develop related to renal function and what drugs they need to avoid. Apart from that, I think just ongoing good care, re-immunization, going back to my third or fourth slide, that's really, especially at that age, to make certain that the patient is adequately immunized as they get closer to school age. I think those are the most important issues. Eye exam, dental exam, those are things also to follow.
Wonderful. Our next question is along the same lines. This questioner would like to know if there are particular types of cancers that have the most late side effects or most likely to have secondary cancers. You talked a lot about, the exact treatment protocols that people had are big indicators, but are there specific cancer diagnoses that are more likely to have complications down the line?
So, yes, that's a good question. I think most of the issues related to late cancer are probably most dependent upon the therapy that the patient received pre-transplant and during the transplant. So, right now it's not clear whether patients who have had reduced intensity or non-myeloablative therapy are going to be spared some of the risk for a late cancer. But that, I think that's an ongoing question. Patients who've had lymphoma, at least in some studies, seem to be more at risk for late cancers. But the differences are not so great that, somebody who's had treatment for lymphoma needs to be particularly more worried than somebody who's been treated, say, for leukemia or for somebody who's been treated for another type of tumor. I think, and actually in most cases for patients with lymphoma, it may be related to the fact that they've received a radiation to the thyroid and to the breast, which may be the reason for the increased incidence there. And then for patients who've had involvement of the brain by CNS leukemia or brain tumor who've received higher doses of irradiation to the brain, they may be more at risk for brain tumors. Apart from that, And apart from the ones that I talked about earlier, the genetic disorders that are prone to certain kinds of cancer, I don't think that there's a real differential in terms of risk.
Okay, thank you. Our next question is, if you were diagnosed with TA-TMA after transplant, are there any long-term effects to look out for? And if, yeah, okay, that was the question. Sorry.
Right. So yes, I mean, I think that's an excellent question. It's a bit hard to answer because I think, individual patients are going to have a different risk, but I think that the risk for ongoing renal not complications, but I think renal function is probably even more impacted by somebody with that diagnosis. And so going forward, they probably have less kidney reserve than somebody who did not encounter that complication. Here again, I would recommend that the patient be studied by a functional test like a 24-hour creatinine clearance or a GFR or glomerular filtration rate to see what the baseline function is. If it's reduced, then I think it's really important that any other issue related to renal function be aggressively dealt with. So if there is residual hypertension, that must be managed very carefully. If there is residual proteinuria, protein in the urine, that must be managed very aggressively. I think a patient should probably be followed in conjunction with a nephrologist who's familiar with the condition and is able to act on that. We have patients who've had TMA, and some of them have recovered and don't seem to have any particular decline in renal function and have had no major change to their management. And we've had other patients who have ongoing issues, even some patients who've had to undergo kidney transplant. So there is a gamut here. I think in conference with their physician and maybe their nephrologist, they can have a much better understanding of what's in store for them. I did make the point that in general, if the hypertension and proteinuria are not issues, and even if the function is reduced, it seems as if that will remain stable provided there's no further injury. And avoiding injurious drugs to the kidney is important.
Okay. This is going to be our last question. For those that are 10 plus years post-transplant and they're no longer under the care of their oncologist, they need to advocate for themselves, and they're curious when they're working with their primary care provider, post-transplant, what are the tests they need to be asking for? What do they need to make sure when they have that annual exam that they're getting?
That's a great question. I think if they want to download that slide set, the third one, the NMDP organization has a website. They obviously have a website, but on that website there is a patient link for long-term studies, and it points out what is important in the post-transplant period for follow-up, and it tells you what testing at what interval. It's even available on, for iPhone and for Google phones. There's an application for that you can use and take it to your doctor and show them what you need to have. I would recommend for that individual, if they're not being followed by their pediatric transplant center, that they either ask their pediatric transplant center, is there an adult group that they could be referred to? Here in Houston, we have an adult team. They're not at our hospital, obviously, but we do refer some to that. And then for patients that have moved to other cities, I often will call the adult programs in those cities, and they're usually willing almost always to see a patient who's had a transplant and follow them, because it's really, as I say, it's one of the important things that we do to try and prevent complications or treat them early so that the quality of life is not impacted in a major way.
Excellent. Yes, survivorship clinics are becoming more and more prevalent, and that is wonderful for our long-term survivors. Well, I would on behalf of BMT InfoNet and our partners, I would really like to thank you, Dr. Krance, for your helpful presentation and remarks. and I'd like to thank the audience for these excellent questions. Please contact BMT InfoNet if we can help you in any way, and enjoy the rest of the symposium.